Thank you, and thanks, Mr. Reid. I want to start with the whole question of testing and tracing, and obviously this is one of the key tools in terms of us living with the virus. I think it would be really helpful if you were completely upfront with this committee in terms of the reasons why you're not using the full capacity of 100,000 tests a day. Will you tell us what is the main threat to having that kind of rapid and agile testing and tracing service in place? Is it a staffing problem? Is it a funding problem? Or what is it that is preventing you from operating a very active, proactive and reactive testing and tracing system? So what's the main threat to that? My second question is in relation to the testing and the meat plans, the 50,000. Who's actually paying for that? My third question relates to the flu vaccine for children, or the drops. What are the arrangements for administering that programme? And my fourth question is in relation to the creation of additional capacity in the private hospitals. Can you briefly just explain to us how you propose to go about doing that? Thanks.
Deputy, I know you've been a strong advocate and in-depth knowledge of the testing and tracing, so fully respect and try to answer your questions as openly as I can, as I always try to do. The approach we've taken very quickly has been to build a capacity for 100,000, both in terms of our swabbing centres, our labs and our contact tracers. Again, as I said, it is all determined by the transmission of the virus and the case definition. Sure,
I appreciate that, but can you just be specific about what is preventing you, or what's the main threat to actually utilising that full potential?
Yeah, so we're guided by the approach recommendations from NEFIT in terms of where to serial test, where to mass test, because they have the depth knowledge of the transmission of disease and the impact of it.
But aren't there issues about staff?
No, we've resourced up to whatever staff are needed, and we'll continue to resource up. So even on contact tracing, we've resourced up even further in the last week. We've gone from 60 to 120. We'll go to 150 by the end of this week. We'll go beyond that next week once the virus determines it.
Okay, thanks. We'll pursue that with NEFIT.
Okay.
Thanks.
Yeah. Just on the, specifically in relation to the, I'm going to ask Colin just on the vaccine, specifically on the meat plants.
Yeah.
And I actually won't comment on one in the first part of the question. Meat plants are funded directly. The serial testing and mass testing is being funded by the state, and HSE funded by the state in terms of everything that's done to date. So that's to say that. One quick response just on the serial testing, and I just want to put this just out for factual information. Serial testing gives the public a lot of reassurance, and I fully respect that, and we will need to continue serial testing in various settings. It is a very significant cost. If you take, just give you a quick example of our serial testing of healthcare workers in nursing homes. In the first phase, we completed 99,750 tests completed over the 4-week period. The positivity rate was 0.13 of that. It's a very significant cost. It's a lot of a resource. I appreciate it gives the public reassurance, but that is not the major tool in terms of protecting the public. And I just want to state that very clearly. The major tool are the public health measures that we can all take. So I know it's a reassurance factor for the public. Sure. Positivity rate's quite low from serial testing. And even
but obviously it's critical that you're geared up to respond rapidly. There is an outbreak.
Yeah, apologies.
Yeah.
And the meat plants, so we are, the state, have completed it.
And in relation to the flu vaccine for children?
Vaccine, I'll come into column second. Private hospitals, if I can just finish on the private hospitals, just the status of it. There are 3 pieces to the response I'll give you. First of all, we have in place what's called a bridging fund. So to see us through, because we terminated the last agreement, and we want a fund to bridge us through to a further agreement. We have a 25 million fund approved by government, and that's being utilised by our various hospital groups for what services they want to draw on that. Secondly, we've issued a tender, which is out at the moment, and there are 2 aspects to the tender. It's for all private hospital groups, private hospitals, tender for diagnostics and a tender for services. And we are working through our services plan for the winter and for next year to agree the level of funding that we will need to draw down from that. And thirdly, for our if in the event we have this massive surge that we had in the first instance, the role of the private hospital groups and their supports for us. We are directly engaged with the groups individually on that. The private hospital groups as a body have asked us to engage individually with them, and we are engaged. And I would be confident that they will do the right thing when that emerges. So that's the three aspects to the private hospital.
You're talking about cost per item, as it were?
Yes, it would be a very different model. It would be a very different model on our first approach.
Acquisitioning beds or anything like that?
Yeah, well, if you take the tender that's out at the moment, that would be based on an activity-based pricing for services drawn down, because as we see it for the next phase, it's not what we had to prepare for. The first phase is a blanket across-the-board capacity. We would see it probably targeted and probably have to be utilised in different regions at different times.
Thank you.
Thank you, Deputy Shortall.
Vaccines for children, no?
Vaccine for children, thank you, Deputy. Just quickly, 600,000 doses of the vaccine ordered for children aged 2 to 12, and deliveries expected in middle to late October. The training information for healthcare workers should be administering this has been developed, and a communications campaign developed too. Now, regarding the administration, the primary care division of the HSE is in negotiations with the IMO on the fee and the administration of this vaccine through GPs, and that's not yet complete, but coming to a close imminently, and hopefully that will have a successful conclusion, allowing us to.
Thanks, Dr. Henry. Thank you very much, and thank you, Deputy Shortall. Thank you.